trocars are positioned as demonstrated. Exposure of the operative field begins by grasping and laterally retracting the sigmoid colon, then creating an opening in the posterior peritoneum between the right iliac artery and the ureter. To enable better exposure of the retroperitoneum, anterior traction of the peritoneal sheet is performed using transfixing sutures on the abdominal wall on the left and right sides. The identification of the right iliac vein serves as a reference for the start of the paracaval dissection. The dissection is extended to expose the anterior wall of the aorta and the left para-aortic space, thus enabling access to perform the intercaval aortic dissection. The origin of the inferior mesenteric artery is identified and dissected. Pelvic dissection begins on the right side through dissection over the bifurcation of the common iliac artery. The dissection is deepened until the exposure of the arcuate line at the boundary between the psoas and internal obturator muscles. After completing the dissection of the right obturator fossa, anatomical boundaries are observed, and the specimen of the lymphadenectomy is placed in a plastic bag. The emptying of the obturator fossa is carried out, with the identification and dissection of the obturator nerve. The uterus is tractioned and extracted transvaginally.